So, shall we start, Thomas?
Yes.
Okay. So, good afternoon to everybody. It's really a pleasure for me to introduce Professor Mette Berger. For who doesn't know her, she's professor of intensive care medicine at the Faculty of Medicine Biology, right, Mette, at Lausanne University in Switzerland. And well, she's one of the most, I would say, prominent expert of metabolism and nutrition in critical ill patients, as well as in patients with burn. The scientific production is quite extensive, more than 300 articles, but more importantly, she has been the chair and the principal authors of several guidelines on metabolism and nutrition under the endorsement, especially of the European Society of Intensive Care Medicine. And I will not waste more time, and I will give you the online stage to start. Go ahead, Mette.
Thank you, Pietro, for this very kind introduction. And actually, it's an honor to be able to participate in your education system. So I will try and I'll make you chair this. I have conflicts of interest, of course, and you mentioned them actually. I'm a guideline person, and that is very important. And I have a critical look on papers with my editor-in-chief job. I give lectures, so that's what I have there. Okay, so let's now start. And the case I will present is a case that Michele prepared for our SMART meeting. And here we are with a male patient, 69 years old, coming in on a Friday night as usual. He's only 55 kilos, he's medium-sized, and his BMI is therefore low, 18. The past history is hypertension and alcohol, and he's under omeprazole, aspirin, and a few other things. He's admitted to emergency department for hematemesis, and he's apneic stable. He gets an endosophagy, and there's no bleeding, but peptic ulcer, and he's actually treated with vasoconstrictor, infiltration, and clipping. But then there is a persistence of bleeding, and he comes in with low hemoglobin, gets some transfusions. Gastroscopy is repeated, this time with actually vasopressor and hemospray. Next day, new hematemesis, selective angiography. He's admitted to the surgical ward after a coiling of the mesenteric vessel with contrast blushing. New bleeding on next day, so now he gets into surgery with a subtotal gastrectomy, distal splenopancreatectomy. So this is really something important. We are now 3 days down the road, and the guy has not been fit for quite some time. So they find on 18th an intra-abdominal fluid collection from the pancreatic stump, and they put a percutaneous drainage in. 10 days later, things are not really getting any better. Ileus, no occlusion, bilious vomiting, and he gets pneumonia and requires intubation and mechanical ventilation for actually respiratory failure. And oops, I'm sorry, I had to do something like that. Gets admitted to an ICU on a Friday night, of course. You see here, we started on 13th. We are nearly 2 weeks later. The colleagues do some blood tests. They found leukocytosis, the modest CRP increase, but a PCT of 5, creatinine, total bilirubin are there. And this time, he's tuberous with mottled skin, tachypneic. He's hypotensive, tachypneic, and actually, before intubation, he was clearly unsaturated. And oliguric. And that was the picture of what they had seen. So then Michele told me that actually they had done something was to start PM immediately from the day they were. He's on mechanical ventilation. He has vasoactive drugs. Okay. What would you have done? He was asking us. As there was ileus, he thought that exclusive PN was the only way to go. While he had a pancreatitis, he thought, we don't know, should we fast him? Or as we have a jejunostomy, should we use it? Or because he was vomiting, they were hesitating with enteral and parenteral. Actually, what they were considering was isocaloric polymeric standard formula, or a liver formula, or semi-elemental formula, and another one, hyperlipidic, because of the respiratory failure. So like the work questions they were asking themselves, we have a multi-organ failure, we have a pneumonitis. Actually, what they did was to wonder also how they would feed him, how much energy, and they considered different equations using actual body weight. That would be around 1,400 calories. If ideal body weight, that would be more. And well, they did enjoy calorimetry, and they found the value of 1,500. They were clearly hesitating to what to do. And as the patient was malnourished, they decided to do a rapid increase of feeds toward targets, but they were considering refeeding risk, which is not idiotic in this case. And actually, they were also considering surgery and sepsis, meaning big inflammation. They were not really knowing what to do. What they finally decided to do was to use actual body weight to calculate a target on day 1 of ICU admission. Then the patient had been for 2 weeks in hospital and had got nothing. They were using early PN in the jejunostomy, giving some enteral. They were using a standard polymeric isocaloric formula. And they were considering the propofol the patient was receiving, which totalizing close to 150 kilocalories a day, providing about 500 kilocalories as PN. And then, and I reacted to that, aggressive prokinetic therapy. That's never a good idea. But that's what they did. And I'm asking you now a question because we have got lots of information. We have a high CRP, we have leukocytosis, we have renal problems. And what would you like to have that was not given until now? Blood potassium, blood glucose, blood phosphate, albumin level. Just think a little about it. Actually, the first thing I was asking was blood phosphate, to have an idea where we were heading. And what do our European guidelines propose you should do in this case? Because they had many data, but I saw no assessment of the nutritional risk. Well, they actually, we say, determine energy needs. The protein will follow because most of our solutions have fixed amounts. And the question is, how do you determine energy target? And then to determine the route, to provide micronutrients, and to monitor. I will go through these different steps. Well, our guidelines, and this is the revised guideline that we published in 23, was that every patient should be considered for feeding if he stays more than 48 hours in the ICU. Of course, life does not start in the ICU. So you should also consider the days before. Here we have 2 weeks. So clearly, to consider an immediate start in the ICU, it's not stupid at all. It is even very reasonable. But medical nutrition therapy should also be something structured. Of course, in this patient who was intubated, oral nutrition was not possible. Was there a contraindication for EN? Well, we have a jejunostomy. But we have also the information that there is an ileus. So we should screen the patient and assess. And this patient clearly has 2 weeks without anything, came in with a BMI of 18. So he's actually due for a more complex management. So that's what we propose as step. How do we assess? Very simply, it should take less than 60 seconds. We have the 2002 NRS. It's based on some nutritional data, BMI. It is low here, so we already got 2 points. Has the patient been eating? Well, no, the surgeon didn't give anything. We have 3 points. So it's the worst of these. We have 3 points here. The severity, I mean, here we have clear and Apache over 10, so we have 3 points also, and he's under 3. So this patient has got 6 points. And I calculated them as I spoke, so it's less than 60 seconds. Clearly, we are in a high-risk patient. Okay. This means, and this we know from Nutrition Day, that this patient at the stage we're getting is a patient where we have less than a quarter of intakes. And the issue with that is that when we are in this category, we multiply the death risk by 6. And that's data from 10,000 of patients. So clearly we are in a really high risk from many sides. And I wanted phosphate. Yes, because as soon as you will start with infusing any amount of energy and any amount of glucose, the metabolism will be reactivated. And one of the complications will result from phosphate and potassium and magnesium going down. This is a survey we published some years back now, and we did a survey in the ESICM, 59 ICUs, 23 countries, and it was a picture, 1 day point of care. And here we have the days the patients were in ICU, and red is the limit of 0.65 of phosphate in blood, which is considered to reflect hypophosphatemia. Of course, most of the low values were observed during the first days, but we had low values until day 85. So having phosphate measured is an obligation every day in ICU. As soon as you measure electrolytes, you measure phosphate. And look at this case, which comes from my own ICU. There's a patient who has, well, he's bad off. It's an abdominal case, but he comes in with a creatinine. We are in micromole of 178, which means he is in renal failure. Not that bad, but you see a phosphate of over 2. We are in millimole. It's quite high. And then he receives some glucose. And no feeding yet because it's unstable. And actually from 2 now, the phosphate will drop down to 0.59 and further to 1.6. Everyone would agree that this is real major problem. On day 2, because the gut was not working, some parental nutrition was started and increased progressively, but below his target. And then gut get better, and we introduce enteral feeding. But he gets a lot of phosphate, actually, to prevent that. We should have given. It's very difficult when a patient has renal failure, like the one that Michele showed, because you have the false impression that phosphate is under control. So you really have to monitor it. Okay, again, I show you this. Increasing mortality with missing data. And then phosphate, okay, but then thiamine. Thiamine is essential for the energetics of the patient. It's just, you have no ATP if you have no thiamine, and the reserves are down. Within 10 days, you have no reserves at all, but they are threatened very early on. So thiamine in our micronutrient guidelines, and it's also in the practical ones, is something that we actually do not necessarily need to measure. But, and this we insist heavily on, any patient admitted to emergency or ICU should receive daily 100 to 300 milligram per day of thiamine intravenously when we are in acute. And this is really to be done without doing any blood determination. You just give it. You just give it. And if you want to measure something and do something, you should, of course, be delivering from the start to this patient adequate amounts of essential trace elements and vitamins, and IV, if in this case, and we determine CRP, because we will have trouble with assessing the level of blood level without knowing the intensity of inflammation. So this patient should have received not only thiamine, but the whole amount, which he did not receive. And since 2009, the ESPEN guidelines state that we should deliver micronutrients every day from the first day, and we have repeated it in all the guidelines. And of course, insisting on thiamine, ascorbic acid, selenium, and zinc. So clearly, you do not see the consequences immediately of not having them, but the biological problems will be there already. And while having optimal tissue function and stores repleted, which is not the case in this patient, you will first have an initial depletion for which there is compensation if there is some food over there. But then without, and we are 2 weeks down the road, the intracellular content will continue going down and enzyme activity will go down. You will have cognitive effects, you will have energetic effects, you will have free radical damage, and it will end with death. These small, tiny things are vital. My question to you now is, when are micronutrient complements or supplements working, being efficient? I propose to you correcting a deficiency, complete an incomplete solution. People often think that parenteral nutrition, because it's called total, contains micronutrients, which is not the case. You have to add them separately. It is essential to know that. When there is inflammation, when you use nutritional doses, when they are delivered in combination, well, all of these are correct. But if you give very high isolated doses, it does not work. So here you clearly have to be addressing these different issues, and you may have to deliver some additional micronutrients, such as thiamine in this case, but you have to deliver them all. And the thing we insist on in the ICU guidelines is that the patients are not the same on the different timings of their stay in the ICU. Here we have got a patient in who is in respiratory failure, has been bleeding, everything is wrong, there's a multi-organ failure. This is the acute phase of disease where patients are catabolic heavily, and it will be difficult to feed them and to make the patient's metabolism accommodate feeding. And then if they respond to our therapy, we say 1-2 days, but it's not exact. I mean, it will depend on the disease process. It can be longer, these acute phase. Eventually the patient responds and gets progressively into a phase where they can respond and eventually go over to rehab or to a chronic phase, which is still another thing. And Annika Heindam wrote this paper with colleagues, and she analyzed what we know from multiple trials. And she looked at the comparison between early full energy delivery upon ICU admission versus studies who had done permissive underfeeding, or studies who had started slowly, progressively. And every time it was confirmed that full feeding was the worst thing to do to the patient. And actually, not feeding also was associated with mortality, more infections, and recovery. So there is a balance to find, and the studies who have done best were those having this profile in progression of energy. And an example of this, because this patient, you've got it, is at very high risk of refeeding, which was mentioned by Michele and the team, but they were not sure how to handle it. This study comes from Australia and New Zealand. And admission to this study was because the patients, upon starting feeding, were developing hypophosphatemia. They were then randomized to what they called standard care, which was to continue progression of feeding, or caloric management, as they called it, which was to stop for at least 2 days the amount of feeding at the level where they were. And what happened? Actually, there was a clear increase in mortality in the patients who had progressed without eating. You might think that this is due to more phosphate in one team or, well, whatever. Look here. This is the energy intake. Clearly, the patients who had management received less. But these are the blood phosphates. They are similar. And on B here, the phosphate doses were the same. The patients on caloric management had more normal blood glucose levels. So clearly, it's not only about phosphate. It's a metabolic alteration that occurs when you first show a low phosphate. It's much more complex. There is research ongoing to try and find out what is going on. But the result here is that when you say, hey, the body doesn't want more now, let's wait, the energy deficit is less important than respecting the stop the patient has given, his body has given. So you will not be able to catch up, and you have to consider one thing which is happening to the patients. We are not mice. We are made to have intermittent fasting overnight because we have to provide to the brain glucose. So we're healthy. We produce roughly 190 grams of glucose every day. The blue bar here in the middle were trauma patients in my ICU on day 3, major trauma. But at the time we did that study, we were bad at enteral feeding, so they were properly starved. We measured energy expenditure, 1,800 kilocalories, and we measured glucose production, 310 grams per day. So that is what the body responds. It's, of course, at an expense of muscle catabolism, because it's where the amino acids come from for neoglycogenesis. And these 2 other bars are another study we did more recently. Patients were elder, 65 years old, and they were entering the study because they were partially fed. They were producing 180 grams per day, 65 years old. And 5 days later, they were completely fed. They were still producing endogenous glucose. Why? Because when you're inflammatory, your body does not stop producing endogenous glucose. So having this endogenous glucose production, if you start early full feeding because you want to do good to the patient, you actually harm him by overfeeding the patient. So this is the reason why we say, hey, people, the patient and the body is telling you something. We cannot stop the endogenous glucose production, even if it's bad, but we do something differently. We progress. Why is this? Now I've given you some answers. The answer is clearly all of the above. There is a risk of refeeding syndrome. There is a risk of hypoglycemia. And don't forget that when you go enteral, there is a risk of intestinal ischemia in patients with shock. So you have to look at what the gut is telling you, and the studies who have given full enteral feeding, I'm thinking of the calories trial and Nutrirea 2, they have experienced more enteral complications. So all this is, there are other potential metabolic reasons, but other personal ones. And this is why we argument in this direction. I'm repeating, if the gut is working, we go progressively. If it's not, EN is replaced by PN, but we also do progress. If the gut is working, but not well, we consider supplemental PN. Again, we are under the measured energy expenditure by indirect calorimetry in our trials. So during the first week, the main issue is to try and catch the response of the patient to what we're delivering, treating hypoglycemia, managing the metabolic response, but not overfeeding. With that, we stay in safe levels. And regarding micronutrients, your patients come in, well, in the acute case, it's different, but there are disease-specific micronutrient depletions. You see that quite many micronutrients are affected. Well, chronic intestinal failure, it's obvious because the absorption is compromised, but also in alcoholism, etc. And with your treatments, with our life-saving treatments, we induce problems also with losses of micronutrients. So it's obvious when we have renal replacement therapy that we are losing water-soluble stuff out with it, which is also micronutrients. But clearly, we are exaggerating the unbalance which was already present. And this is why we say, while you are progressing feeding to the patient, deliver micronutrients in this very early phase. And we are a series of large European ICUs who deliver for 5 days at least multi-micronutrients intravenously to our patients while we are starting, because we are ramping up the feeding. And feeding is not covering the basal needs. We are screening for hypophosphatemia, correcting whenever, delivering thiamine, and these are the normal PN doses. It's not about delivering enormous amounts, except if you have the proof of a loss. And then, well, you know, there is hospital malnutrition. Which are the causes? Because the patient comes in malnourished, that's the first option, but there are other potential causes. One of the causes for malnutrition, could it be delay initiation of nutrition therapy? Could it be the absence of monitoring the delivered nutrition? Absence of dietitians? Absence of a feeding protocol in the ICU? What do you think is most important? Well, they are all correct. And of course, your patients come in a bad state, else they wouldn't be coming to your ICU. In the end, you are thinking, does this obese patient need feeding? Oh, yes. And if you don't have a computerized system, you are not really seeing, you prescribe maybe correctly, but what is the patient receiving? Not so sure. And if you don't have dietitians in your ICU who just playing the watchdogs, I'm saying this very kindly because we doctors tend not to take care of nutrition, then the patients are bad off. We have nurses, dietitians who do that every day, and they watch for every patient who on day 3 is not having anything. We have a 40-bed ICU, so there is a lot of work and movement. So computerized system helps us looking at that, but we have a feeding protocol. So when the dietitian, who is not a doctor, comes to the doctor and said, hey, we have a protocol, this patient should be fed, it has an impact. So try and get dietitians to assist you. And I'm saying that the patient is not receiving what you receive. You might have seen this large cohort study who included close to 1,800 patients. And they looked for the 12 first days. They categorized according to BMI, but that's not so important. We just look at the first columns here. It was a very nice surprise, actually. The prescription was quite okay for the first 12 days, 24 kilocalories per kilo a day. The protein prescription was absolutely according to guidelines, 1.2 grams. The problem was what they received. 1,000 calories instead of 1,800, which means 14 calories per kilo a day, and proteins even less. So if you don't monitor, it just does not work. Don't trust your prescription. It's not working. It's not working if you're not watching. And this is systematic with very few exceptions. And the problem is that, and this I was very happy to have introduced with actually Per Singer already back 20 years back, the concept of accumulated energy deficit, inspiring ourselves from an American study, actually. And we looked prospectively. The both studies had the same design. It was really funny. We didn't know about it each ourselves. And we looked at energy expenditure, measured it, and looked at what we were doing. And in both ICUs, a modest deficit of minus 4,000 calories had no problem. And then we sort of saw something was happening here around minus 6,000 kilocalories, which is close to 100 kilocalories per kilo. We were seeing all types of complications increasing. And when we had reached the 10,000s, all patients had a complication that was not recognized as underfeeding by my colleagues, but was, ventilator-associated pneumonia on day 8 is often malnutrition. And the problem is, when you see it, you cannot catch up. Exceeding 110% of the measured energy expenditure is just resulting in complications. So when you have the gap, it's gone. And this was nicely shown by an American study, actually. The title was actually telling the result, saying that adequate nutrition may get you home. And they looked at energy balance and protein balance using 1.3 as target. And they looked at in-hospital mortality. It was just not significant. But discharge to home was 3 times more frequent in those who had not experienced those big deficits. So clearly it impacts. These were surgical patients. And then the root. We insist on the fact that there are many options, that when the gut works, we use it, but we should go. I had just told you before about the 2 studies who have confirmed equipoise between enteral and parenteral when you use the same amounts of energy in both. Because enteral has actually been protective in many studies comparing to PN. The early studies, I showed you that people are not receiving what they get prescribed. In this study, they did a great job. This is a British pragmatic study where they had ventilated ICU patients, 2,400 in both studies. Target was 25, and they looked at mortality 30 days, nothing. And PN patients had less hypoglycemia because enteral nutrition you are on off, and less vomiting. The French study, the first Nutriria 2, was actually in sick patients. They were in septic shock. And same targets. Here also, they achieved the goals within 30 hours. So it's amazing. Okay. Again here, mortality was not different. Well, this was not significant, 37% in the intro, okay, versus 35. But more vomiting, and this was highly significant, more diarrhea, okay, that's obvious, but also more bowel ischemia and acute bowel pseudo-obstruction. So forcing the gut early on is wrong. And this is why I said aggressive prokinetic therapy has been shown to be a bad thing to do to your patient. When the gut is not working, it is telling you, please have a look at what's happening to me and to my gut. So you should really not try and force it. Modest doses 2 times, okay. But as soon as you see the word aggressive appear somewhere, you are hurting your patient. So here we are into the recommendation we did within the ESICM. We always suggest using enteral nutrition and even using it early, even in patients with shock, when shock is controlled. What does that mean? It does mean that you are not increasing anymore your norepinephrine or whatever vasopressor you use. You are not increasing your fluids anymore. You are on the way down, or at least stable. Then you may consider doing it. But, and you see the parallel between ESIGM and ESPEN. ESIGM, with the presence of Annika Reintam, focuses on GI function, while ESPEN focuses on energy. And both, we say the same with different wordings. It starts at slow rate, carefully monitoring abdominal response. Increase slowly when symptoms are resolved. Do not aim to cover full energy with early enteral. I mean, that was in 2017. We already said, hey, people. And this was published when some studies were started, and we were cross with them because we knew they would fail. And avoid overfeeding. We insist. And how to cover energy? Well, actually, during the first days, you can take whatever weight, it's the actual pre-fluid resuscitation weight you should consider for calculation of an equation, because when you do indirect calorimetry in the early stages, you don't get a metabolic proper information for feeding. So we say, okay, 20. And if you use equations, be very cautious and do consider high levels only at the end of the first week. Start with going there, even if you have indirect calorimetry by day 3, day 4. We know that some deficit is tolerable, and it's worse to full feed. And this has been nicely shown by Pierre Singer and his team. I mean, these are 1,300 patients and 5,000 indirect calorimetries. And you see that the optimal survival rate is here, under 100. And of course, if you go too low down, you have increased mortality. Proteins, it's not clear, but solutions with high protein content are not very frequent. So we insist on this early overfeeding of macronutrients. And you see that even you can overfeed a poor fish, and this one needs a balloon to float because it's real bad for everyone. So, carbohydrate, hyperglycemia, hypertriglyceridemia, hepatic steatosis. Fat also. With the proteins, you have uremia, acidosis, etc. You get refeeding syndrome, you get hypercapnia, and you get ventilator weaning failure and infections. So bad to do that to your patients. Here we have something from the burn world, because when I started with burns, we did indirect calorimetry, and the American recommendation, they had the largest experience, was to deliver at least 1.5 times what we measured. We had fatty livers. Look here. This is the caloric balance, as they call it. It's the multiple of measured energy expenditure. And that's the change of weight. Fantastic. Weight increases, huh? You see that? The problem is that when you exceed 1.1, remember 110% of measured value, muscle mass does not increase, it's only fat. So in acute inflammatory patients, there is no interest in exceeding what you measure and on going on the high side. But if you go below 1, then you also lose weight. So you have to find the balance there and look at what you're doing. And to understand what happened to parental nutrition, you need to consider the history of it. You will not understand the crisis and the discussions if you don't know that. The Harris-Benedict equation is 2019, no? Very good study. And the first amino acids were found by William Rose. Arvid-Retlin produced some by enzymatic hydrolysis. And then we had the first lipid emulsions. And in the United States, they had bad luck. They used cottonseed and had lots of anaphylactic and inflammatory responses. So it was forbidden in the United States. That's why they have been using solutions without fats. In Europe, we were lucky to have my Swedish colleague Arvid-Retlin, who used nutritional sources, soybean and egg yolk. And since we in Europe have had intralipid, which was pure omega-6, but which was not giving such reactions, and we got crystalline amino acids from 64, and then we started in the early 80s to get mixed medium chain triglycerides, which reduced the complications from omega-6s, and we also, since end of 20th century, had omega-3s. I've been doing research in the early 90s with omega-3s. Got stricter lipids, and then the blended emulsions, and they start here. And then actually, you see this, EPANIC comes here, and calories and nutriurea come there. And something happened that compromised parenteral nutrition. This is an American study conducted in 12 volunteers who had had either enteral feeding or PN for 7 days without anything else. And then they get an endotoxin injection. I've used the same model to test our patients' omega-3, you will see it later. And what happened? The subjects who had got TPN got an overreaction of everything, including of epinephrine in blood, and they were more inflammatory. How was this interpreted? PN is bad in inflammatory patients. And what happened? This comes from my ICU. We were a unit using in blue a lot of PN. This trial came out. We decreased our use of PN and increased enteral. And then here, we realized that we had malnutrition because enteral nutrition was bad and we were not using sufficiently PN. So from that time, I've been fighting in favor of using PN because the gut does not work in our patients. And that is how it looked when I started with PN in the 80s. You see, the prescription required some knowledge. I have my PhD, so I was able to do these prescriptions. Luckily today, we have multiple bags, and for the sickest patient, we have glutamine, but we always have vitamins and trace elements next to it. But it's much easier. But it's not understood. And maybe you saw this paper we published November last year in Critical Care, because there is a study going on which is called GutForce, and we have 28 sites participating. And all of a sudden, when Annika and her team were trying to enter the results of the patients, because this GutForce is a gut study, and to objectively tell that the gut is not working, people were told to tell if the patient required PN. So PN information was required. And look at that. People considered that glucose 5% was PN. the definition of PN is not understood. Clearly, PN is only understood by some people because some are using just amino acids or just something else. The centers which were using 3-chamber bags were the bigger centers. The others were more creative, and you could observe this. This is wrong. This is wrong. This is not PN. And actually, we know that the issue comes from a wording issue that we identified. Before total parental nutrition, we skipped total and said just PN. And people have misunderstood that. So when I say people, it's quite many centers. And PN is the provision of nutrients by the IV route. And total is that you have no other source of feeding and provide all nutrients. You may do that with supplemental strategy, meaning that you complete an enterally insufficient solution. It can be peripheral, like in some surgical patients where the gut after ERAS is still not working in a few patients, and you have a peripheral cannula and you can give something. But if you have to provide all, it's carbs, amino acids, and lipids. The proportions can vary a little, but there should be no feeding today without omega-3 containing solutions. You should provide electrolytes and water, and you should provide micronutrients. There are hard indications, prolonged ileus, and in this case, Miguel and his team was right. The patient had not been properly fed and the gut was not working correctly. Something had to be done. Short bowel syndrome is one of these with mesenteric infarction. Severe malabsorption can be one different, and excessive time to enteral or all. If you know the patient who is sick is not going to have proper feeding before end of the week, is due for something. In the end, can be PN. And insufficient energy intakes, be them oral, like in hyperemesis gravidarum, when it lasts many days, it's then compromising also the baby. So you should even consider it in obstetrics when it's going wrong, when you may have a peripheral one or something like that. And it can be the indication to complete something that has gone wrong. And this was shown, you see, when this study comes, Graham Hill from New Zealand actually was the first surgeon to show that things were going wrong if you did not do that properly. And he took patients who had actually major surgical problems, and they had lost weight when they come to him. And in some of them, he started PN early, and in others not. Look at 200 days here, how much faster the patients recovered when they were managed early. And total colectomy was frequent at that time. Clearly, we haven't learned much since. And it's important to know the differences between your enteral feeding solution and the parenteral ones. Maltodextrins are used in the carbs, glucose in the other. For the proteins, because of the way it's prepared, you have a full blend of polymeric amino acids, and you have glutamine. You're probably not aware, but you feed enterally, you are delivering obligatorily, because it's not possible not to, 8% of glutamine. For stability issues, there is none in the parental feeding solution, and that is one of the reasons for metabolic relative inefficiency. The parental solutions have finally got all triglyceride combinations, and of course they contain no micronutrients. When you feed enterally a patient's 1500 calories, you provide the minimal basic things. You cannot correct the deficit, but you provide it, but not with PN. And this is why actually we have been doing this like a strategy we've been using in Geneva and Lausanne for many years, and that was our Swiss SPN study, where we wanted to show that this energy difference mattered. And we randomized patients who were not being fed properly by day 3 for whatever good or bad reason, and we randomized the patient to continue on pure EN or to supplement to measured value because we didn't even break calorimetry. And we did that for 5 days. And we looked at what happened. Important. The patient started with this small minus 4,000 kilocalorie deficit roughly. And then we had a nice separation between the groups, but we did not exceed the measured value in the patients. So we did not change that. On the others, the patients with enteral, they increased their deficit. This is how it looks. Well, actually, the energy target might have been wrong. We measure, we adapt to measured, and we complete with parenteral until enteral works. It's only 3 days, no problem. But during that period, the patients do not get deficit. And if you look at the blood glucose, 8 millimole is here. You see that our intervention is not doing any harm to the patient. We have perfect control on the blood glucose with small doses of insulin. And the result is a significant reduction in infectious complications after day 9. Because these patients have a body composition which has not been as badly treated. Less antibiotics, less inflammation, better immunity, and 3,339 Swiss francs less per patient on SPM. Because less of infections. So, are there questions that have been upcoming? I don't see them. It's important before we go into the substrates. Important questions, please.
I am collecting the questions. If you don't mind, Mette, we can do them all at the end.
Okay, perfect with me. So then let's go for the proteins. We are stubborn in Europe. We stay with this small amount of protein, 1.3 gram. It's not a small amount, by the way, but we are against the larger amounts, and we stay by that because we know from isotope studies that it doesn't benefit the patient. In the burns, we also add glutamine. And some nice studies, and this is the study by Christine Kokuk, showed very nicely that the strategy matters. She categorized the patients, and it's 40 and 55 patients, and she looked at small intake of protein, less than 0.8 gram per kilo, more than 8 gram, and a progressive strategy over the first 3 days. The progressive strategy had a better cumulative survival. I mean, not randomized, but an ICU where you have perfect control of what is delivered with a computer system. Clear. Then you look at another ICU where there is a perfect control with computers. It's that of Pierre Singer. And again, then they looked at the patients who were in sepsis actually and looked for early protein or late protein because you know that there has been a controversy there. And actually the administration of early protein, not massive amounts, but this progressive way, instead of waiting until beyond a week, was associated with better recovery. I could show you several studies like this, but clearly we should be delivering proteins, but in amounts which are reasonable. Now regarding fatty acids, well, you know that it's long been known that you should have for the kids some cod liver oil. This is myself with my doggy receiving my cod fish oil. The dog received it also. So I have grown up with fish oil. That's clear. It's traditional. You know, I'm Norwegian. So that's like it is. But it's not something that is without impact on the whole population. These are statistics that come from the World Health Organization. This is an Indian study done by this organization, and looks at non-communicable diseases, communicable diseases, and so on, and the death rate, looking at the omega-6 to omega-3 ratio. Yep. Clearly, you reduce the the non-communicable diseases with improving the rate of omega-3s. And why is this so? Actually, the mechanisms are now perfectly well known. If you have a shock, a heat, or injury, you have a standardized response with the different chemokines. And if you deliver with the feeding only omega-6s, it will be enforced. If you introduce omega-3 fatty acids, you will attenuate it. It's clearly done. And we now know that we have the SPMs, which are actually metabolized in the body from the omega-3s, which resolve and actually will reduce inflammation. In kids, and this comes from Paris from Necker, who have intestinal failure and who are on continuous PN, if you just put them on intravipid, it was at that time, you will observe over time an increase in direct bilirubin and all the liver tests. From the time they had fish oil, this is what happened. It spares the liver, clearly. So when you have a patient who needs PN for a prolonged period, no way you should use the pure omega-6 solutions anymore. And this has reduced in kids the number of liver transplantation dramatically. And why is this so? Because the fish oil emulsions improve the liver function by better bile flow, by immunomodulation, as I showed you, and by reducing steatosis. And absolutely objectively shown by several trials. The liver loves fish oil. When you have a patient who needs PN, should receive even pure fish oil. And Lorenzo Pradelli, whom you probably know, being Italian, has done several studies, meta-analysis. This is a Sukra way to present data, where the dots represent the number of studies who have been included in these different analyses. And he's in the 4 images comparing medium chain triglyceride, olive oil, fish oil, and soybean oil down here. And why are there 5 graphs? Because he took 5 items available from the studies: infections, sepsis, ICU and hospital length of stay, and hospital mortality in adults. Every time it was the fish oil which was the winner. So the evidence is there. It's 47 RCTs. It's even increasing. And it's most pronounced in the surgical patients who have the most important inflammatory responses. And we are fighting muscle loss, muscle catabolism, and sarcopenia in some diseases. And there also, omega-3s have now been shown to be extremely important in maintaining myogenism and muscle regeneration. If you have, and studies are numerous, I'm not showing them, muscle damage, this results in inflammation or inflammation from the disease. This results in catabolism, and you can then attenuate using omega-6 solutions by increasing the SPNs, which are metabolites of them. You cannot eat them. You have to receive API DHA to generate them and generate resolvins, maresin, and protectins. Studies have been increasing for the 20 last years. So if you want to maintain your muscle, the muscle in your patients, you have to include omega-3s. And the mechanism is as follows: external omega-3s, long-chain fatty acids, they're incorporated into the cell membrane, and they are metabolized to SPMs, which will reduce inflammation. Well, if you don't look at the other side, NF-kappa B activation will be inhibited, and this means that you are going to have less muscle catabolism, and you will also actually facilitate the mTOR pathway. So the mechanisms are absolutely clear. And then you monitor. Because I told you one of the problems we have with feeding is that you prescribe maybe perfectly, but you have to check what is happening. And we have written it, which are the tools that are available to check if your medical nutrition therapy is working and is doing no harm, because actually you might be wanting to do very good and deliver large amounts, you're harming. Is it daily blood glucose? It's daily electrolytes. You see phosphate is written bigger than the others. Blood triglycerides, liver function tests, prealbumin. Is any one of these wrong? No, they're all correct. And this is what we advocate. You should do, this is the minimum you should be doing, because of course, be also checking that the prescription is really delivered. And you should also be checking body weight, of course, to see how water is going on and out. And actually, prealbumin, people have been laughing at me for 20 years, but now they start laughing less. I had introduced this in Married to Bones. They have prealbumin once weekly, not more, just once. But they have it on ambition, and then we look. This data comes from Emmanuel Pardo in Paris, from Les Hôpitaux de l'Assistance Publique. And he has over 3,000 patients and close to 5,000 prealbumin levels, and he has the full energy delivery and protein delivery. It's not prescription, it's delivery. They are computerized also. And what does it show? Here, down here, you have CRP. They belong to centers who have been using, like we have been doing, CRP on a routinely basis quite frequently because it's cheap and it tells you which direction the patient goes. Delta CRP by day 7, plus, minus. And then you look at energy intake from 0 to 30, and you look at prealbumin values. Actually, of course, in the inflammatory patients, it's not working. But as soon as you have an inflammation which decreases, you can see how it works. And prealbumin will signal you that you are doing the right thing. Same for protein. So it gives you one isolated value is of no use. It's the repeated value which tells you if the patient is responding or not. And if it declines, you should be checking your prescription, checking the energy expenditure of your patient if you can, checking what's happened. If it goes down, something's wrong. And here I'm back. Actually, it's really about watching your patient, considering if you have, as in Miguel's case, a clear indication to PN, this is PN, but progressive. And then you go there. Regarding micronutrients, if you have a normal status and develop a deficit, all metabolic pathways is going to be wrong. And restoring them will take 5 to 7 days because it's not like a drug. Micronutrients and nutrition are not working instantly. So trials which test for 2 days, they are just stupid and have no idea about physiology. Or single doses, it's just stupid. And if you give high doses, you may even have harm, at best no effect. So for micronutrients, it's also clear. You respect metabolism. So does correcting vitamin D status in this case work? You possibly have heard about the EFFORT trial, which was conducted in 8 hospitals in Switzerland. And some of these patients had vitamin D determination. And actually, this is what happened. If you look at vitamin D deficiency, clearly you have a higher mortality in the graph up here if you have a deficiency. Well, this is internal medicine department, and some of the patients actually were treated medically, others did not. So again, not treating worsened it, but in the patients who received continuous treatment for vitamin D deficiency, you could restore mortality. Clearly, it works, and in short time. So the take-home messages are, please assess your patients. Beware of refeeding syndrome. Start early, but progressively, watching what your patient tells you. Provide micronutrients daily from start, and observe, observe, observe. I mean, this is really about respecting the size of your patient and what you're doing, because it's individual. And that's my take-home message. And if you want to know more about micronutrients, we have created courses which are available for free online. So here we are.
Thank you so much. This was really a beautiful lecture. So many relevant information that we will have to go through them again and again to get them all. But thank you very much. This is really very helpful. So I have collected some questions. The first one is about phosphate. Just give me a second. So the first one comes from Martina Baiardo-Redelli. She's a colleague from Varese, and she asks, in case of hypophosphatemia, besides adjusting nutrition, do you also reintegrate phosphate? If yes, which is your threshold for reintegration? And I connect to this one also another question that arrived, which is about phosphate in AKI patients. In this population, is hyperphosphatemia, might it cover some problems? Or what about renal replacement therapy that might induce hypophosphatemia if we use solutions without phosphate?
Well, I will start with the later questions about renal replacement therapy. Some centers are using replacement solutions with phosphate. In France, that is very common. And that prevents it to happen because, of course, you lose phosphate. By the way, hyperphosphatemia can be one of the co-reasons for introducing renal replacement therapy. So, okay, usually it's several reasons, but hyperphosphatemia is treated that way, and then you will have to compensate for that. The French centers are using solutions which contain physiologic concentrations of phosphate. Okay. You don't have it, you just give it IV and you give the normal requirements and you monitor. Now, yes, renal patients come in with hyperphosphatemia, like I showed you on the figure I had at the start of it. And when you treat adequately the kidney, phosphate tends to go down. And if the patient has not been fed, I will show you, I will go back out of this mode and go back to that picture I showed you here. Here we are. Sorry, where was it? I had it here. Yeah. That was the patient who came in with high phosphate, received some glucosaline. It went down because the patient had not been fed, and we had to deliver actually phosphate at some quite high rates. It was clearly needed. So I cannot give you a recipe. I don't have the dose. You have to monitor and see how the patient responds to it because the volume of distribution can change depending on the therapy you're doing. So you would start with delivering actually amounts which can be 10, 20 millimoles an hour to correct hypophosphatemia, and then you look at what is happening. You have to monitor, clearly monitor, because you see, we knew and we did not give enough. So we went steep down. And there you have trouble. I mean, then your patient is not conscious anymore, etc. You have weaning failure. You have everything. You can have as trouble from electrolyte problems. I hope this answers.
Absolutely. Thank you very much. So another question comes from Dr. Murazzani. She's a resident from our university. And she asks if, in your opinion, the muscle could be a target for nutritional support, and what you think about muscle ultrasonography is it reliable? Is it a feasible tool to monitor muscular changes in critically ill patients and the response to ongoing nutritional support?
Well, I've been using it in randomized trials. So BIA is reliable regarding phase angle. Regarding volumes of muscle during the early phase, there is too much water and it messes up your interpretation. But to have the changes over time is useful. So when we did it too early, we started the intervention by day 4 and we had the outcome BIA by day 15. 10 days is not enough. You have to put it longer down the way. But then it becomes something interesting. The phase angle already shows you something. So when we started in our very sick patients, we had a phase angle of 3.2, and those who had received the intervention actually went up to 4.5, and it was significant. So while the others were lower, and the difference and the change was significant. So it can be used, but the response which is most reliable from BIA early on is phase angle. And then, of course, it is useful to have to calculate muscle mass, but that is when water is out.
Okay.
So clearly, sorry.
No, I was asking, so this is BIA. Do you also have experience or an opinion on muscle ultrasound? So evaluation, ultrasonographic assessment of muscular mass?
Yes, and this was actually the same because we did it simultaneously. And the ultrasound assessment was the one where we had no clear response in 10 days. So we have images, but they are not as clear as they get later on in disease. So clearly the water makes it underperform. So 10 days is not enough. You need to have longer watch outs. But we were a referral center, so the patients were discharged out of our ICU to other ICUs when they're good enough to go. So we could not have later measures.
Okay.
So
Thank you.
yes, ultrasound is working, absolutely. And we did it simultaneously with BIA. Sorry, I did not answer correctly to your first question.
No, maybe I didn't say it correctly myself. So there's another question which I find very interesting about PN. So the question is if you're using off-the-shelf products or if your pharmacy is preparing them for you according to your prescription. And also, this is very technical, but it's a good question, I think. Why do you think that PN preparations don't contain micronutrients and therefore set up for errors like you showed us?
Well, we are using both. And we're using compounding only for special patients, special size, extreme sizes to avoid. And sometimes we want to have higher proteins, and we are compounding with glutamine for the sickest patients in the early phase. Actually, for the first, when the PN goes beyond 3 days, we have recommendation, which is first to piggyback the glutamine on the industrial. And sometimes we also have to have more omega-3s. I mean, the pancreatitis, when the gut is really not working, we are using pure omega-3 instead of the 4 different mixtures. So we are doing some compounding, but the compounding is much less than the industrial for cost reasons. And they have improved. So clearly, the problem they have is that they are a bit diluted. And this is why we piggyback the glutamine on them in the sickest patient. We never do that on the ward or in stable patient. I mean, it's the very acute phase. I mean, glutamine addition is only required in the sickest, and those who lose lots of it on renal replacement therapy and have a non-working gut. Because as I told you, on enteral feeding, you receive some glutamine. So, okay. And now, why are the solution not containing micronutrients? Just for stability issues. So this is the simple reason why they are not including it. Baxter came to me to discuss this, and they had a project to have on every bag on PN a chamber with micronutrients. but there was not sufficient demand at the time where this was planned.
Okay.
So they did not do it, because we could have had a multi-chamber bag where there was one chamber for micronutrients.
Yeah.
That would have been simple, because then the stability issue was not there. So clearly, that was the problem of insufficient demand at the time they were thinking of it.
But it could be something in the future, maybe.
Yes, it is absolutely possible. It's also, I mean, I have put on this picture again about one size does not fit all. Clearly, this is also true for the micronutrient needs, etc. And as soon as you have to compensate for one because there is a deficiency that you have to correct, you cannot prepare the bags for that.
Yeah.
So in our ICU, we deliver them at night over. We infuse them slowly over 3 to 6 hours, depending on the lines available, at night shift, because that's when the nurses have least to do.
Yeah.
So,
Perfect sense. Yeah.
it is an important factor. We are a team.
Absolutely.
So
there's another question. This is actually my own question on one size does not fit all. I was very interested by the endogenous glucose production, and I wanted to know how it is actually measured.
it's stable isotopes. It is stable isotopes, and we don't have actually. One of my doctorants did a thesis on that to see if we had alternatives to stable isotopes, because the stable isotopes you get the answer two months down the road, so it's absolutely useless. And actually, what we could see from the patient where we had done these studies was that you could actually, when the respiratory quotient on the calorimetry was going high, you could consider that there was a problem. But CO2 production and oxygen production, actually, I could show it. Isabel Uda, who was the first author on that, but we don't have absolutely reliable stuff. So we actually, insulin dose shows you that something is going wrong. So when you need high doses early on, you know that you have a high endogenous production. That's sure.
Right.
And then CO2 rising is also one, but it's not 100% indicator. So we look at the blood glucose and the insulin dose.
Because ideally, if you would know how much at the bedside, how much endogenous glucose production you would have, you would change your nutrition accordingly. Is that correct?
Does that mean that you reduce only the glucose? No, you would reduce all.
Yes.
And that is a thinking, that is an important thinking error which has been made by many who were investigating this, because our organism needs glucose and it needs a balanced intake of all substrates. So, but it's about the global tolerance. So yes, if we had the answer, we could actually go for that early on, and this is why we have been trying to find out, but we could not find better. And it was the blood glucose, which in the end was the one who told us where we were. You remember this one, it's that. And we were so surprised in the last study we did to see that by day 9, we still had this high production, but it was related to inflammation. So inflammation is the answer. High CRP, you can be certain that you have high endogenous glucose production. So look at insulin levels and at CRP.
Thank you. Thank you. I think we can come to
that's research. That is research to be done.
Yeah.
Please do.
It's really, really fascinating. Absolutely. So another question that arrived is about accumulated energy deficit. And the question is if this is, so to say, a research tool, or if you have this value displayed on your charts as well, if you make an estimate on the sickest patients.
that is displayed daily in our charts. The delta between intake from propofol, glucose, nutrition is displayed, and it's calculated when you enter your target, daily target. It shows you, well, we are in minus this day, and we calculate the cumulated. So that is on all our charts. And it's a daily information window. So clearly, this delta matters. Where was this? And actually, clearly, we have this here. So when we enter this area, we know there is danger. Then we have to, it should not happen, but it does. I mean, over the weekend, it does. Because the patient actually entered Thursday, but things happen, had to go back to surgery, etc. And you come on Monday, now we are there. Then it's tricky, because if the patient has not been fed at all, you have to start from start, meaning progressing. But you should not go the slippery way further. So to have it displayed on the computer system helps people and the nurses. With that, we could show actually in the major burns that when the nurses see that on the screen, that, oh, then they know that they have to increase the rate of their feeding, because in the burns we have multiple interruptions of feeding due to repeated bandages, theater, etc. So they increase the rates in between, just managing based on this calculation.
Thank you. I have another, if you can give us a suggestion, because I feel very humble, and we are, personally, I feel far behind on this, and I would like to improve our clinical practice. Where should we start, in your opinion? So there is an ICU that wants to improve the way they take care of metabolism and of nutrition of the patients. Where should the group start?
Well, first look at your data. Look at your own data and look at what I showed you here. Where was this? It was here. I mean, we had a wake-up call when we saw our data. It was the paper we published with this increase of complications, and where we watched what we were doing. So it starts by you becoming aware of where your most important problem are. Then it is sitting down with the nurses, the physiotherapist, the dietitian if you have one, and the doctor. The leader should not be the boss of the ICU. It should be a person who can listen. So it can be a doctor, but it should be one with capacity to listen. And you sit down and listen to the problems they all have. You can also have the pharmacist on board. I've always had my pharmacist on board. Where do we have problems? And then you see the protocols which are available on the line, and you see what can we adapt? What is our problem? So it is a process which is not immediate. It takes knowing where you're standing, what you use, and then teamwork. So that's what I would do. I saw the question rising up with citrates.
So the question, I will read it. I think this is the last one, and then I will give the word to Pietro to close the webinar. So the question, which are from Elena Moitz, is: we know that citrate in CRT is to consider as calories. It's not clear how many.
Sure. Depending on the rate you're using, it's between 200 and 300 kilocalories of carbs. So it is to be considered. So you may, in patients on renal replacement, end up with overfeeding.
Okay, so depending, so according to the millimoles per liter that you use, and on the time the machine is on.
Yeah.
So it's an estimate also there, but it's you said 200 to 300 calories per day.
Yes. Yeah. But it's at least 200.
Okay. Thank you very much. Thank you really so much. I will give the word back to Pietro for the closure. You're accepted.
Okay. Thank you very much, Mette. Let me just highlight one of the most impressive aspects that you have mentioned, and I really would like to highlight it also for our residents and junior doctors, the importance to measure what we are, prescribing, but what we are also giving to our patients. It's the same issue that we have also with the renal replacement therapy and the gap between the target dose and the real dose that we are giving to our patient. And I think it's extremely important what you have said the very last part of the talk, that we need to measure what we are, from which point we can start just measuring what we are doing on a daily basis in our patients, and then from then it's the perfect starting point. I really would like to thank a lot for your time, for accepting this invitation. I really found your presentation quite fascinating, as I had the same experience when I was able to meet you at the Smart Congress. We had always a lot of passionate and very fascinating discussions on clinical and scientific issues. So I really thank you very much a lot. And I think this is the last seminar, right, Thomas, of this year?
Yeah.
So
it's a perfect closure. Yeah.
Exactly.
It's a good way to close the season.
Exactly.
Thank you. It's an honor. And I just thank you for what you said, just Pietro. I know nutrition, people are talking about beliefs and of cooking recipes. It is not. It is physiology and metabolism that you can measure. And as soon as you start measuring, your interest increases. So thank you for pointing to this and giving me the opportunity to share this with you.
Thank you. Thank you very much. And goodbye to everybody. And it has been really a pleasure.
Thank you.
Thank you. Thank you so much. Bye, everybody. Have a nice
Bye,
afternoon.
everybody.
Bye, bye. Thank you.
Bye, Luca.
Bye.